Steve Fuse couldn't be with us today. He and his wife are enjoying a new baby at home, and so he asked me to help him out this morning. It's my pleasure to welcome back Dr. Allan Brett for part two of Grand Medicine Year in Review. A couple of housekeeping items. There's no Grand Rounds next week, as a reminder. We are back in 2 weeks with Dr. Safadi discussing colorectal cancer screening in older adults. For those that couldn't be with us last week, Dr. Brett is returning today for part two of his talk. He did his medical school at University of Pennsylvania, residency at University of Pittsburgh, and has spent most of his academic career at Harvard Medical School and University of South Carolina. And he has served over 30 years as editor-in-chief of NEJM Journal Watch, a publication that just recently changed to NEJM Clinician, and continues to serve as editor-at-large. He will be reviewing with us several topics from this past year's publications. Please place any questions in the chat. We will try to address them as we go through each portion of the talk. Thank you very much, Dr. Brett.
Thank you. After two introductions in 2 weeks in a row, I'm going to plunge right into the talk. And again, as I said last week, the slides have all the references. So if you're interested in reading one of the papers that I review, you don't have to jot it down. I think everybody who's in attendance will get the slides emailed. All right, so here's the topics for today. Cervical radiculopathy and carpal tunnel, 2 big randomized trials, screening for primary aldosteronism, a guideline, obesity and total hip or knee arthroplasty, anticoagulation after ablation of AFib, as needed inhaled therapy for asthma, incidental findings on CT. And if we have time, I added a controversy over a new community-acquired pneumonia guideline. All right. So the first, I'm going to combine these in sort of one segment, and then we can take the questions. They're both randomized trials on these 2 compressive neuropathies. First, cervical radiculopathy, and then in a moment, carpal tunnel. Surgery is usually reserved for patients who have intractable pain or significant progressive neurodeficits. And we're going to talk for a moment about a randomized trial. It's the largest randomized trial done on this particular entity. It was 180 patients referred to a university neurosurgery or PM&R department. And to get into this trial, patients had to have at least 3 months of disabling radicular arm pain, plus neck pain, plus documented nerve root compression that corresponded to the radicular aspect of the presentation. It was depending on which, they looked at a bunch of subgroups and gave the duration of symptoms, but it was between 6 and 12 months for most patients had been symptomatic. And the important part of this one, as at least the authors claim, and I think it's correct, is that they separated out patients whose symptoms were related to clearly a herniated disc and those whose symptoms were more likely due by imaging to cervical spondylosis. And patients who had myelopathy, in other words, signal on the MRI showing that the cord itself was involved with a process, those were excluded. 2/3 had sensory deficits, 1/3 had motor deficits, and they don't say how many of these are overlapping. So presumably some had both and some had neither. These are on the first exam when they presented to the specialty clinic. So as I said, they were randomized to surgical or non-surgical management. And one of the key take-home points here is the 2 different groups. In the herniated disc study at 1 year, scores for several different symptom inventories, neck pain and disability and arm pain, separate scales, were significantly better with surgery than medical management. And it was the equivalent of roughly, this is the mean score, of a point on a 10-point scale. So modest, it did make statistical significance. And then the other analysis was the proportion who at the end of the year said, I'm either better or much better than I was before, compared to no change or worse, was higher in the surgical group than in the medical group. So 25 percentage points difference there, which was statistically significant. Although important to see that more than half the patients in the non-surgical group said they were better. And in contrast, in the spondylosis sub-study, there was no difference at all on any metric between surgery and non-surgery. Whenever you see a surgery versus non-surgery trial, always look to see how many crossovers there were. The results I've given here are intention to treat, what group the patient was in when they were randomized. And as you can see in the DISC study, there were very few, just 2 crossovers from non-surgery to surgery, whereas there were 11 in the spondylosis study. And they don't give any details on neurologic improvement. It's like a 1-sentence thing about grip strength was unchanged in both studies from beginning to end of the study. And then the second one here is carpal tunnel syndrome. This is also the largest randomized trial ever done for carpal tunnel. And in this study, it required having symptoms for at least 6 weeks. The median was 8 months. And these were patients who were recruited from neurology clinics in the Netherlands. So presumably they were a little bit more severe than, initially presenting patients to primary care. Half had sensory findings, about half had motor findings. And like I said, some presumably had both or neither. And these are all documented by either nerve conduction studies or ultrasound. As an aside, ultrasound has become a legitimate way in the proper hands of somebody who knows what they're doing to diagnose carpal tunnel, pretty much comparable to electrodiagnostic studies by operators who are good at this. And they were randomized here to surgery or steroid injection, which could be repeated a second time if necessary, and followed for 18 months. The outcome was a standardized scoring scale for carpal tunnel that's been used in other studies. The mean going into this study was something like 20 out of 30, higher being worse. And based on other studies, they counted an outcome of less than 8 as being substantial improvement. And sort of like the other study, when you break this down by percentages who had, quote, good responses, it was 61 versus 45% favoring surgery. They also just asked the global questions. How do you feel about your improvement? Are you satisfied with your treatment? And again, it was about 20 percentage points favoring surgery in this study. Now here, crossover was half the patients in the steroid injection group crossed over through the 18 months. It looked like they had a chart. It looked like it was kind of equal, spread out over the 18 months. It wasn't all right up front. And so again, this is intention to treat. These are comparing patients who were randomized initially, but in the steroid group, over time, half of them ended up having surgery. So in sum, for both of these, I put them together in this one segment. On average, for cervical radiculopathy, surgery was somewhat better than no surgery at 1 year. Again, if a patient had, quote, disabling pain for at least 3 months and the cause was a herniated disc, there was no benefit at all when the cause was cervical spondylosis. And then for carpal tunnel, on average, starting with surgery was somewhat better than starting with steroid injection, looking at 18-month endpoints, if the patient had had bothersome symptoms for at least several months. So my takeaway here is that for both conditions, outcomes weren't dramatically decisive. Some benefit for surgery in the groups that we talked about over 12 to 18 months. But I think for both of these, it's decent information to share with patients who are trying to decide what to do with either of these, where you can kind of look at the natural history for the 2 different options and share that with patients who may decide in either direction to start with surgery or not. So I'll stop right there. Okay. Primary aldosterone screening, 2 guidelines. Do people pretty much know that these organizations in the past year promoted early hyperaldo screening? Yeah, okay. In 2025, the sort of repeated, updated AHA-ACC guideline on hypertension was published. And you could spend, I guess, a whole hour on that, and that's what we're not going to do that. It actually doesn't have that much difference from its previous one, which was, I think, in 2018, about thresholds for treating and all that stuff. But they did talk about this. There's one segment where they basically say in adults with stage 2 hypertension, screening for primary aldosteronism, quote, may be considered. And in those guidelines, they show what language they use correlating with the strength of the recommendation. And they called it a 2B recommendation, which is considered weak and reflects consensus of expert opinion rather than randomized trials or a good database. And then the Endocrine Society published a primary aldosterone guideline. I think the Endocrine Society was the only US society that's actually published any guideline on this. And their last one was 10 years ago, or it's 2016. And this one basically went further than the previous one. And basically their language is exactly as follows. We suggest that all individuals with hypertension be screened for primary aldosteronism by measuring aldosterone and renin and determining the ratio, and that subsequent clinical care be guided by the results. In their rating system, this is also conditional low certainty. And I think, it's kind of interesting when you see guidelines and you just read the first sentence of a segment, we suggest that all individuals. If you stop there, it sounds pretty straightforward, if not emphatic, with the word suggest. And then you go to the end and you see it's conditional low certainty. And then if you read about their grade guidelines or whatever, it means that there's a lot of uncertainty there. So basically, they go on to say it's conditional depending on contextual factors such as available resources, local expertise, and healthcare system capacity. What does that mean? I don't know. I mean, there's not much elaboration on that. I think that's sort of coding for an unstated, this is a big deal. And now I'm kind of extrapolating. And there's a lot of rabbit holes that you can go down when you start doing this on everybody, as we're going to talk about for a minute here. And so, I mean, healthcare system capacity, I don't quite know what that means. And the reason it's not straightforward there's several reasons, but the first one is that renin aldosterone testing is not straightforward. Their guideline says to count as having this diagnosis, and then there's very extensive algorithms, tables and algorithms in the paper. It would take a whole grand rounds to go through that, actually. Basically, the cutoffs depend on the lab. Does the lab measure renin by plasma renin activity versus a direct measure? And aldo, I sort of hadn't thought about this before. It can be measured either by immunoassay or liquid chromatography mass spectroscopy. And you probably don't know which is used in your lab. And there are many studies over the last 10, 20 years showing that it really matters where you draw your cutoffs here in terms of sensitivity and specificity. This is one of those situations where almost always the cutoffs for, say, the ratio at a certain point to maximize sensitivity really harms specificity and vice versa. So it's not an easy one. The article goes into a whole lot of detail with guidance about if you have concern for false positives and false negatives, what to do with borderline results, potential effect of the drugs. They recommend stopping aldosterone antagonists if you can in the patient, but they do recommend as a first pass testing, except for aldosterone antagonists, testing the patient while they're on drugs. But then they say, but if it's a borderline result and the patient's on drug X, you might consider trying to withhold it for 2 weeks or a month and so forth. It gets convoluted, okay? And when to retest. And then at the end of the guideline, well, not at the end, but as you work through it, there's really detailed guidance based on all these different things on directly trying to treat the patient with an antagonist of mineralocorticoids versus evaluating the patient further downstream with an aldo suppression test, adrenal CT, and adrenal lateralizing testing. So I think that's the last slide there. So again, to go through this in detail, would take a whole grand rounds in itself. But that's where we stand. And I guess I'd be interested if anybody has an idea on this. I think that for patients who are well controlled on a decent regimen, I'm not sure that we ought to take the plunge and start measuring these things. Obviously, this excludes patient with resistant hypertension where you want to look for secondary causes. This excludes people with hypokalemia, not being on a spontaneous hypokalemia, but they keep making the point, and the literature does, that these days we're finding so much of this that a majority of patients with primary aldo don't present with hypokalemia. So a patient who's newly diagnosed and is on no drugs, that's probably the time to do it, actually, so you don't have to worry about some of these factors that might contaminate the results. So, comments?
Just a comment. I've got two patients who have slightly high aldo levels, who endocrine is recommended, so they're off their beta blocker, they're off their ARBs, their blood pressure's up higher, you got to wait 2 weeks to retest. And yeah, and then there's that whole question of, do you do imaging, do you do lateralizing? So it is it some ways just feels better to just put them on spironolactone and dial it up to get them under control.
Yeah, I was going to say, I have a patient who is clearly hyperaldosteronism, and like we went with the adrenal CT and the IR sampling, and she's on 25 of spironolactone and her blood pressure is like 102 over 68. And then I'm like, okay, so did we not, could we have just done a trial of spironolactone and spared her all of this kind of torture?
Yeah. There's a whole page algorithm in this. You probably ought to print it out and have it on the side or something like that. But there is one arm. If the patient has a straightforward result that's not super high, because the higher it is, apparently, the more likely you're likely to find an adenoma and get lateralizing numbers that might push toward surgery. But on the left-hand side of the thing, there is the just go ahead and empirically treat. And I've read other experts over the last 10 years since the last guideline who say we just ought to do more empirical treatment. And I guess it's now probably in most practices a favorite add-on for patients with resistant hypertension who are on 2 or 3 agents. Although, there are side effects, so the gynecomastia and so forth. So it's not a completely benign thing to do. So, okay. Move on. Great. So again, I recommend, if you're going to be doing this in some patients, look at the thing, copy the the algorithm, and just have it there in case you need it. Obesity and total joint arthroplasty. So we're going to talk here about the surgeon who says, I'm not operating on your patient unless their BMI is below X. And I had that happen to me several times before I moved here in 2021 when I had my own practice. And I've had residents at the VA present this scenario to me several times. So I think it's out there. Many people don't realize that in 2023, the American College of Rheumatology and the American Association of Hip and Knee Surgeons, a collaborative guideline from orthopedists and rheumatology, published a guideline where they recommended against rigid weight thresholds that delay total joint arthroplasty if the patient fulfilled those 4 things: advanced osteoarthritis, moderate to severe pain and or loss of function, no improvement with at least 1 non-invasive intervention, and a desire on the patient to move forward with surgery after a process of shared decision-making, talking to the surgeon about the pros and cons and benefits and risks of doing the surgery. And in this past year, 3 observational studies were published that sort of indirectly support this perspective. They're observational, they're not any randomized trials. And I'm going to present those 3 quickly. They're all published, by the way, in the Journal of Bone and Joint Surgery. That's a flagship journal of the American Association of Orthopedic Surgeons. So this is coming from orthopedists, not from non-orthopedists. The first is a Canadian single center study of 10,000 patients who had total knee arthroplasty with 9 years of mean follow-up. And this is patients seen over like 15 or more years. So it's a large database with a lot of follow-up, but admittedly one center. And 6% of those patients were operated on with a BMI greater than 50. So 600 out of the 10,000. And what they did was they looked at the risks for revision, another procedure after surgery by virtue of their BMI, as a function of their BMI going into the surgery. And they found that the risk, which constituted revisions for either infection, aseptic loosening, or instability, was not increased compared to BMIs less than 30. It was not increased for BMIs from 30 to 35, 35 to 40, and 40 to 50. They divided that into those three groups. It was only with BMI greater than 50 where the risk for revision was statistically higher than in non-obese patients. And as you can see there, that was just limited to the first post-op year. And it wasn't a huge numerical difference. It's 3% versus 1% in the other groups had another procedure in the first year. And then after that, they show the curves. They're all parallel. So that 2 percentage point separation occurred at the beginning, and then they were parallel through the mean 9-year follow-up. And these authors conclude, contrary to BMI of 40 as the presumed threshold for increased risk, which seems to be what a lot of surgeons are using, these findings suggest that the inflection point may be closer to 50. And then they say this challenges existing beliefs, ... Regardless of their increased risk, these patients reported more improvement than lower weight patients. They also, in their database, followed patients' satisfaction with treatment and improved symptoms. And they actually found that the greater than 50 group had higher scores in terms of satisfaction and benefit than those below. So that's the final point. And then they actually even stray into, some ethical issues about communication with patients and taking patients' preferences into account. So that was that one. And then the second and third studies were two studies that were identical in format from Mayo Clinic. There were patients with obesity who had total hip or knee arthroplasty. There's two separate papers for the two joints, but they read almost exactly the same. Mean BMI 36, mean follow-up 5 years. And what they did here was they looked from 1 month to 2 years pre-surgery what the patient's weight trajectory was in their records. So this doesn't look like actually, so they can't say in how many of these patients they were told you should lose weight before you go into surgery. It's just an observational thing. In both studies, losing 10 to 20 pounds or greater than 20 pounds during the 2 years before surgery was not associated with lower risks for complications or reoperations compared to people whose weight was neutral or who lost weight. And those were all statistically equivalent. And then again, just sort of reading the final paragraph, these results call into question whether preoperative weight loss alone is enough to reduce postoperative complications. So I think there's a decent observational literature combined with, the fact that these patients can be very symptomatic, that we should not use a hard cutoff. And before I moved here, I had several patients when I had my own practice who fit into this. And the surgeon said, I'm not doing this. And I was in a smaller setting where I basically knew personally most of the orthopedic surgeons, and I talked to them. I would never put a gun to the head of a surgeon to say, cut on somebody you don't want to cut on. I'd never do that. That's not good. But I would have a discussion. And in most cases, they went ahead and did the surgery for people with BMI. And my patients that this came up were in the low 40s, actually. I don't think I sent somebody during my practice with a BMI over 50. But so I'll stop there. I think that's the last one here. Yeah. Surely you've seen this on occasion. Everybody's nodding.
Yeah. I was curious because I've also worked in settings where there's been hard roadblocks on BMI numbers for hip and knee replacements. I always assumed there was evidence behind that. Do you know where those beliefs or practices came from?
I'll be honest with you. I didn't plunge deeply into the literature beyond these studies, but some years ago when this started to happen, a resident and I, so I'm talking maybe 10 years ago, we looked at the data, and it was both for A1Cs and weight. And interesting, there was a bunch of observational studies in Sweden, as I recall. I hope I'm remembering this correctly, with big databases that basically showed that, yes, there was a higher incidence of wound infections that sort of correlated with obesity, that when you adjusted for obesity, it was trivial for having diabetes. And when you sort of adjusted, it came out to be the weight, and then the theory is, a lot of tissue there and so forth, it has more of a chance of getting infected. But you didn't really know how well those patients' diabetes were controlled. And then there was always the business about, is it the A1C the 3 months before? Is it their sugar the week before? What's the time interval where reflecting the diabetes control? Is it intraoperative and postoperative high sugars? It's a really complicated thing for the diabetes. I might add, I didn't put this in the slide, that the guideline from the 2023 guideline from the American College of Rheumatology and the orthopedists do talk about diabetes too. And that bullet in the guideline, I wrote it down here, is, and I quote, for patients with poorly controlled diabetes, we conditionally recommend delaying total joint to improve glycemic control. But then I just sort of paraphrase, but they refrain from giving saying that there's any cutoff, a specific cutoff that they can honestly say is the right cutoff, basically.
There was a comment in the chat, more a comment than question, keeping in mind that Mayo is a very big referral center and tends to attract a lot of patients with more complicated care needs. They wonder how comparable the patient population in those studies were at Mayo compared to the average patient we might see elsewhere.
Yeah. I don't know. I really don't know. A lot of patients go to Mayo Clinic because of its reputation. And since this is a pretty standard diagnosis, did the Mayo Clinic, do these patients have a whole lot of more people with sort of like, aseptic necrosis and all kinds of other reasons that people will get joint replaced as opposed to osteoarthritis? Maybe a little bit more, but my guess is for something like this, it's probably more the skill and expertise of the surgeon in there, wherever they are, at least in the United States, rather than the institution. So if the Mayo Clinic attracts orthopedic surgeons who are more skilled or something like that, then maybe yes. But I don't think, unlike really complicated tertiary care diagnoses that people fly to the Mayo Clinic for, I don't think that's as big an issue, but I don't know the answer. All right, keep going. Anticoagulation after AFib ablation. The reason I covered this one for this audience is that I've just been impressed by how many people are getting ablations in recent years. And we see these patients sometimes in primary care who don't see the cardiologist anymore, and they're still on an anticoagulant. And you wonder, the patient hasn't had any breakthrough AFib that we know about. Do they need to be on this drug, indefinitely? A 2023 guideline from the American College of Cardiology basically says after catheter ablation of atrial fibrillation, long-term oral anticoagulation should be done if the CHADS-2 VAS score is greater than or equal to 2. And then they say this is not based on randomized trials, it's just based on consensus opinion. So 2 randomized trials were published to address this question this past year. First one's a South Korean study. This is published in JAMA. And it involved 840 patients without evidence of recurrent AF at 1 year after ablation. And then, because this CHADS-2 VAS seems to be driving these guidelines, it's important, we should look at what the distribution was. And it was 2 exactly, and 40%. It was, if 30% had CHADS-2 VAS of 3 or 4, almost nobody was above 4 in this study. And then the other 30% were 0 or 1. And they were randomized after being on, this doesn't, and by the way, this doesn't involve several months of anticoagulation, which I think the guidelines still demand, but it's when you stop the anticoagulation after ablation. And then they were randomized to continue or stop anticoagulation and followed for 2 years. To detect breakthrough AFib, they did Holter monitors, short-term Holters every 6 months over the 2 years. And then, of course, if a patient had symptoms, they were asked to come in, have an EKG to see whether they were having breakthrough AF. And it turns out that it occurred in 9% in both groups. So 90% by this metric were successfully treated. And at 2 years, out of 420 in each group, you can see the numbers there in the single digits. 1 stroke in the no anticoagulation group, 5 in the anticoagulation groups. Interestingly, or numerically, there were a few more in the anticoagulated group for whatever reason. No major bleeding events were in the no anticoagulation group, and there were 5 in the anticoagulation group. So again, numerically more with anticoagulation, that one you would expect. So basically, this one argues for at least people with the distribution of CHADS2 VAS scores that you saw stop anticoagulation at some point, say in the first year or so after the procedure. And then the second one was in the New England Journal. This is a 1,300 patient trial. Half are from Canada and half from 4 other countries. These patients, like the other one, had no evidence of recurrent AFib 1 year after ablation. The score was greater than or equal to 4 in only 10% of patients. So we still don't have data on people with really high scores for either of these studies, but these intermediate scores of 2, 3, and 4 were pretty well represented. And they were randomized to rivaroxaban or low-dose aspirin. By the way, in the Korean one, the doctors could choose whichever anticoagulant they wanted. This one was rivaroxaban or low-dose aspirin. And if you wonder what's with the low-dose aspirin, it's very interesting. They're coy about this in the article itself, and even I looked at the protocol online, and they don't exactly tell you. And I don't know whether it's motivated by, as they planned the study, they thought patients wouldn't accept no treatment, so they wanted to have a token treatment for quote equipoise. And it turns out, for people who are a little older in the audience, way back when, before DOACs, and when we went, and way back when we didn't even necessarily anticoagulate all patients, the early randomized trials looked at no treatment versus aspirin versus warfarin. And aspirin in high-risk people was actually a little better than no treatment, but it paled by comparison to warfarin in terms of strokes. So it does have a little bit of effect based on those studies years ago. And then, but the bottom line here is at 3 years, again, numerically, there were very few events in both groups. 7 strokes with aspirin, 5 with rivaroxaban. That's negligible difference. 4 major bleeds with aspirin, 10 with rivaroxaban. So numerically more, as you'd expect with the DOAC. And then the non-major but clinically relevant bleeds, those are the ones that don't land you in the hospital or a transfusion, but require a visit to a medical provider, was statistically significantly higher with rivaroxaban by 4 percentage points. So in sum, for this one, long-term anticoagulation appears unnecessary if there's no documented AF recurrence a year after ablation based on these 2 trials, with this caveat about the high CHADS2 VASC scores. And both, and I just put quotes here, the Journal Watch summaries for these studies was an EP cardiologist at Texas Southwestern, and he concluded these studies support discontinuing anticoagulation in patients with no recurrence after ablation, but I'm still somewhat concerned about patients with CHADS2 VASC scores greater than or equal to 4. But then he goes on to say, I've communicated with this guy many times over the years, And he seems like a pretty practical, patient-centered person. And he basically goes on to say, if it's a borderline call. If the patient would rather not be on anticoagulation, I'm very happy to honor that request, basically, no matter what the score is, if there's no evidence of recurrent AFib. And then there was an editorialist who basically said the same thing in the editorial that accompanied the New England Journal, the 1,300 patient study. So I think that, we see a patient that's been long-term, it's now a year or more after they've been ablated. I think we can recommend stopping it at least for patients like those in this trial, perhaps in communication with the cardiologist, if the patient's still seeing the cardiologist. Nope. All righty. As needed treatment for asthma. So 1/3 of patients, according to several studies, 1/3 of severe asthma exacerbations occur in people considered to have, quote, mild asthma. And that's mild asthma is kind of a fluid term. But the point is that in the overall population, even though more people have what we would call mild asthma, they're not that symptomatic most of the time. Then severe asthma, numerically, there's so many of those that it turns out that patients who end up having severe exacerbations have to go to the emergency department and be on steroids, comprises about 1/3 of severe exacerbations. Now, the guidelines that are mostly respected now for asthma treatment are the GINA guidelines. That's the Global Initiative for Asthma. It's an international guideline, and that's what most pulmonologists and allergists now use as the go-to guideline. And I think by now, after a number of years, after the last 5 years or so, most people recognize that those guidelines recommend combined inhaled steroid plus beta agonist for as-needed rescue treatment for all patients, mild, severe, and in the middle. In other words, in theory, we're not supposed to have patients just using an albuterol inhaler anymore, even if they have mild asthma. In the US, a combination of albuterol and budesonide was FDA approved for as-needed use about a year ago, and it goes under the brand name Air Supra. And there was an ad I was watching the Olympics a little last night, and with all the drug ads, there was an ad for this in the middle of the NBC's Olympic coverage. And we're going to talk about this one, but we're going to broaden this in a moment. And Air Supra is only FDA approved, as it should only be, for rescue therapy, not for maintenance therapy because of the albuterol component. And in studies that got it FDA approved, it was shown to improve outcomes compared to albuterol alone when used as rescue therapy in patients with moderate to severe asthma receiving daily maintenance inhaled steroid plus beta agonist. So this is on top of somebody on daily maintenance. And those are the studies that got it approved. The question is, what about patients with milder asthma? And that's what this study looked at. This is a drug company funded study that was in the New England Journal. And they had 2,500 patients with symptoms not optimally controlled despite treatment for mild asthma. And I didn't put in the slide for time's sake the criteria to be in this study and what counted as mild, because it was a really long thing. It was a combination of the patient's subjective symptoms on questionnaires, whether they had had any ER visits in recent years, and a bunch of other things, and how often they used their albuterol rescue, which had to be pretty infrequent. And in entering the study, so 3/4 of the patients only were using as-needed albuterol alone, and 1/4 of them were on as-needed albuterol plus a low-dose maintenance steroid. But they point out, as we know, a lot of patients who have mild asthma don't bother to take their maintenance steroid. And they were randomized to as-needed albuterol alone or the combination, the albuterol budesonide in one inhaler, Mean follow-up was 8 months, and a severe exacerbation, which was a systemic steroid plus an ED visit or hospitalization, was significantly less likely with the combination, 5% versus 9%, and that was highly statistically significant. And so, even though these were cases that sort of were considered mild, there was probably a spectrum in there, and in the at least one group, 1 out of 10 over 8 months ended up having an ED visit and were put on systemic steroids. So where we stand now is, as I said before, albuterol monotherapy is no longer recommended for anybody. And the question, of course, is, we all have patients who, they have a presumably legitimate diagnosis of asthma at some point in their life. They say, I almost never use my albuterol inhaler, a couple times a year. That kind of patient, should we say, oh, you have to have a combined anti-inflammatory plus rescue now? I think you could say that's up in the air. But ideally, patients who require but for the other patients who require daily maintenance treatment, which are the more moderate to severe cases, should receive steroid plus formoterol for both maintenance and reliever. And the acronym that's now used in literature is MART, maintenance and reliever therapy, or SMART. Formoterol, why is formoterol the go-to drug there? Because it's both long-acting and rapid onset, whereas salmeterol, which is the long-acting component of Advair and its generic ones, is long-acting, but it is not rapid onset. For patients with milder asthma who don't require daily maintenance, ideally, they should use as-needed combination therapy with ICS formoterol. That's still considered to be the number one by most specialists, but ICS formoterol is not FDA approved in the United States for rescue therapy. It is in Europe. So then you start having the cost and the insurance and sort of who is going to, it gets complicated. Or you could use, again, if you're not using maintenance but just rescue, you could use the new combination one, the ICS albuterol in the single inhaler, or you could give it in separate inhalers, a cheap albuterol inhaler plus an inhaled steroid that the patient then, it gets more complicated, right? Use both of them when you're using as needed. I tried to figure out the cost of this Air Supra. Looking up, I didn't call a pharmacy, but I looked at GoodRx and Smart and Single Care. What they show is the study without their discounts, the cost without discount. It looks like it's over $500 for a 120 120 puff inhaler. And you can get an albuterol for something like 30 some bucks now. Albuterol used to be expensive too, but you can get that cheaply now. And some of the single steroid inhalers you can get much cheaper. And generic budesonide formoterol looks like that's about, if you're paying cash, $200 instead of the $500 for the new one. So it's still probably more cost effective if the patient's willing to use 2 inhalers for rescue rather than one, to do that. Or if their insurance covers ICS formoterol for reliever and not just maintenance, that's probably the way to go in terms of cost effectiveness. So, okay. Comments? Yeah.
Question sort of beyond this study. Do you know there's been any head-to-head comparisons between the ICS formoterol and ICS albuterol?
Oh. The answer is no. There's not been any head-to-head comparison. I did sort of see that. The question was, the ICS with formoterol versus ICS versus albuterol, is there head-to-head? I saw one article that says if you actually look at all the data, it looks like, but they're not the same studies, it looks like the ICS formoterol may be a little bit more effective than the ICS albuterol as rescue. Presumably because albuterol is so short acting, and if you need the rescue, the formoterol gives you more hours of coverage.
So my understanding is one of the things that drove this guideline is evidence that monotherapy with albuterol actually increases EO counts. And so there's this thought that it actually may worsen the asthma over time or increase the risk of exacerbation. Do you know, is that true with the longer acting beta agonists?
The first thing you said.
So increasing eosinophil counts. So the suggestion that actually people become more, their airways become more atopic with acting beta ag.
I don't know. The question was with frequent use of solo albuterol, some evidence that it actually increases eosinophilia. I'm sorry, I don't know anything about that. Yeah.
Is there any data or recommendations on how often to use these? I mean, if you don't get relief from the first puff,
Yeah,
or the second puff, or
yeah,
whatever.
I think for the branded one, they say 2 puffs at a time with no more than 12 during a 24-hour period. So it's a lot. Yeah, and that's what was allowed in the randomized trial here. It doesn't say how many people actually used or if they tracked that, but people could use up to that. We're told not to exceed 12 puffs. And for the ICS long-acting formoterol, I think it's something like that as well.
Question from the chat. Any updates related to exercise-induced asthma?
Oh, that's really, how does this apply maybe to exercise-induced asthma? Is that the question maybe?
Yeah, I think that's what they meant.
Yeah, it's interesting because just a few weeks ago, I was precepting and there was a patient who really had a lot of good follow-up, but it really sounded just from his history like he has exercise-induced asthma and he uses a monotherapy albuterol before exercise. Does this apply at all to that subgroup in terms of the added anti-inflammatory part of it? I didn't know either, and he was very happy with just the albuterol and didn't seem to have sort of more spontaneous breakthrough episodes of wheezing. So I don't think there's any data on that. That's a great question, and just saw it a few weeks ago. Okay. Pay attention to, let's see, time here. Okay. Incidental CT findings. Radiologists are supposed to report coronary calcification on lung cancer screening CT scans, and that's actually a formal thing now in the radiology guidelines. They don't always do it, but increasingly they do. And the question is this clinically important? So this is a Canadian retrospective study of 1,500 people with no history of MI or coronary revascularization who had lung CT screening for smoking, according to standard criteria. And it was fascinating. And, thinking about it, I always like to look at the screening CTs to see if it mentions coronary calcification on it. And with the residents, if we have time, often we've pulled up the images and flipped through, and then we found so many cases where you can see calcium, and the radiologist didn't even bother to put it in the report. And in this study, these were pretty heavy smokers from the baseline data. 50% had mild to moderate coronary calcium, and 30% had extensive. And they had a scheme that they described how they classified it. They took the 3 major coronary arteries and the left main, and they divided each of them into 3 segments. So there were 12 segments in the 4 arteries. And if you had 6 or more segments where they could see calcium, that counted as extensive. If there was 1 to 5 segments, it was mild to moderate. And then there were people that had 0. And they have a reference that correlates somewhat with the Agatston scores that you get when you just order the plain coronary calcium screening. During mean follow-up of 4 years, let me just pause again. We've known that these patients have a lot of calcium. This is the first study that actually then looked at what happened to the patients. That's why we covered it. During mean follow-up of 4 years, there was a 5% incidence of adverse cardiovascular events in the extensive group versus 2% in both the 0 and the mild to moderate. So their classification of extensive seemed to have some predictive value here, and that was significant after adjustment for other risk factors. And the implications for practice, I think, are that it can have, if we pay attention to this, it can make us take another look at how well we're managing the patient's cardiovascular risk factors. And at least in one case, I've used it as a tiebreaker in giving a statin to a patient who was resistant to taking a statin, showed him the scan and basically said, yeah, let me start it. If there were independent reasons that the patient might be a candidate, of course, for a statin. That's what it looks like. This is from the article, and it shows calcification, this nice linear calcification. It's not nice in all three arteries. And then hepatic steatosis. And you now often see that as an incidental report, either in a chest CT, because you're seeing the liver at the bottom of the scan, or a abdominal and pelvic CT done for another reason. And this is a meta-analysis that compared non-contrast CT to liver biopsy for steatosis. If you're wondering, where'd they get data? A bunch of patients had both a liver biopsy and sort of incidentally discovered steatosis. And it was really interesting. It's almost all liver transplant donor candidates where you have to have imaging and a biopsy before they'll allow you to give the liver to somebody, a piece of your liver to somebody. And there's thousands of patients in this meta-analysis. So it's pretty powerful, although this is a unique baseline population. So any steatosis, it was not bad, sensitivity and specificity, and at least moderate steatosis by criteria that they describe is pretty good, sensitivity and specificity. It doesn't give you predictive values here, but it's these numbers are comparable to ultrasound, let's say. I think the implications for practice, we've used this several times where we've seen a patient who's at risk for metabolic associated steatohepatitis or steatosis, and nobody's ever really thought about it with the patient. And then they have a chemistry panel, and the AST and ALT are a little bit up. I say to the resident, let's see if they've ever had imaging for anything. And you go back in their record, some of these patients, you wonder why they had so much imaging, and you see, and there's, incidentally noted is steatosis in the liver. So that's one way to use it. Nobody's suggesting that you should do CT to screen people, but so many patients are getting CTs for so many different things that it's there to look at to help deciding maybe whether to go further with a workup in such patients. Time for my last one that we were talking about? Okay. 6 minutes to go. All right. So the last one I wasn't sure whether I have time for this one, but I asked some of the people who were here just before 8, and we thought it would be a good one to go through. This is an interesting controversy. In 2019, the American Thoracic Society and the Infectious Disease Society of America collaborated on a guideline for community-acquired pneumonia that's been quoted quite a bit, and it covers all aspects of diagnosis and treatment. In 2025, a guideline was updated by, initially was going to be updated by both societies in collaboration. And the update only looked at 4 aspects that they thought required update. It wasn't one of these comprehensive ones. And you read the article and it says, the committee was constituted equally of people from the American Thoracic Society and the IDSA, but it has not been endorsed by the IDSA. And that's right there in the article, which was published in the American Journal of Respiratory and Critical Care Medicine, the flagship clinical journal from the ATS. And initially, it was unclear if you just read it, that when it came out, what's going on there. And then it leaked out kind of that they disagreed on antibiotic use for possible bacterial co-infection for patients with pneumonia who test positive for respiratory virus. That was one of the 4 questions they looked at in the guideline. So the guidelines published in July of 2025. In December, two articles appeared in Clinical Infectious Diseases, a big journal for the IDSA, one of which was said, "We Dissent" is the title, and then the other is a more toned down discussion of the issues. The "We Dissent" one basically claims that the ID people were kind of marginalized in this process. And they go into all these accusations, where the meetings were held, this and that. And then in January, like 3 weeks ago, there was a reply from ATS members who disputed the account from the IDSA people. So I don't know who's right or wrong, or the truth is probably in the middle somewhere. And, I'll leave it to you if you want to read. It's really interesting. But here's but what I wanted to present here, because this could come up, for example, patient seen in ER, they do a respiratory panel, you do the follow-up, they have some consolidation, and, should they have been, or should they be on antibiotic or not? The ATS, they divided patients into 4 groups. And by the way, there's almost no data on this. This is all consensus opinion. And the ATS recommended antibiotics for 3 out of the 4 groups. The IDSA recommended no antibiotics except for severely ill inpatients. So the 2 middle groups there's disagreement. For the no comorbidity outpatient, they agree no antibiotics. And so there's all pages of all of this discussion, but just sort of put into 2 sentences here. The ATS basically argued that the potential harms from not treating potential bacterial co-infection, even if it's unusual, but you don't know the diagnosis at time 0, outweighs potential harms of antibiotic overuse. The IDSA argued bacterial co-infection is not common, and they seem to think that they were being accused of only thinking about the public health and resistance, but not your individual patient. And they take pains to argue antibiotics have side effects like C. diff and all these other things in individual patients too. So it's both public health and in your individual patient. Except for the severely ill inpatient group, they argue that missing bacterial co-infection, not treating it, might have harms there. But a close reading suggests actually that the 2 groups are closer than they initially seem. And I'll tell you why here. This is the last slide here. The ATS, here we go again. You read the thing and it says, "We recommend antibiotics." And then you go further. Every one of them is a conditional, very low quality evidence recommendation. And then they explicitly say, should be individualized per clinical judgment. And they have fairly impressive tables in their paper showing factors that strengthen or weaken the recommendations. And there's a whole list of things that they say you should take into consideration when you're individualizing it. And the comorbidities, when you say an outpatient with or without, what counts as a comorbidity? They show you the agreement and disagreement. So for example, is diabetes a comorbidity? Only 30% of the 16 committee members thought it should be. Underlying pulmonary disease, should that be a comorbidity? 80%. And then there's like 20 comorbidities that are all over the map in terms of agreement. So this is a pretty fluid sort of thing. So that's where they come towards the center. And the IDSA authors in those response pieces, basically they do say several times, antibiotics may be warranted if in some non-severe cases, according to clinical and microbiological data, et cetera, use your judgment. So, and then finally, on top of all this, 4 weeks ago, Clinical Infectious Disease published a retrospective study, 7,000 hospitalized patients who had positive tests for virus and probable pneumonia. And basically the study showed no difference in outcome in patients who got antibiotics and those who didn't, in terms of length of stay, need for ICU, or mortality. I actually read the paper carefully. It's one of these database dredging things. There's so many potential flaws in it that I think it's a piece of information, but it's not necessarily the end of the story in terms of trying to prove one thing or the other here. So 9 o'clock exactly. So take this one home with you, and if you want to see 2 groups arguing with each other about a guideline, you can pull the papers in the references.
Any last questions?
Markers, biomarkers is mentioned in that table of things to push you one way or the other. It's interesting that there's not a whole lot of discussion of that in the actual guideline of using that as a tiebreaker. But yeah, but it's actually mentioned. You can't see this, and people at home can't see this, but the table of factors that strengthen or weaken the recommendation, it's all this small print. It's pretty good, and they mention what you mentioned. They also talk about double sickening, which I've heard used for sinusitis. You know, a person has a cold, they're getting better, and then they come in with more fever and sinus pain, and they talk about that and whether that's a good marker for bacterial co-infection. You know, upper respiratory infection, blah blah blah. Start to get sicker after getting better. They get sicker. They have an infiltrate on a chest X-ray. Does that mean that there's a higher incidence of bacterial co-infection? That's the implication here. I don't know if that's been proven.
Well, thank you very much,
You're
Dr.
welcome.
Brett. Appreciate a very informative talk.
Thank you.